Hello, everyone. This is Kate Myers with the California Healthcare Foundation and want to welcome you to today's webinar, SB1004 Technical Assistance Series, Topic 5, Strategy Exchange to Address Common Challenges. And if any of you listening in on today's webinar have not participated in our past SB1004 Technical Assistance Series webinars and or workshops, this is, as the title implies, the fifth in our series and final topic to be addressed in this series of technical assistance. Our faculty, Kathleen Kerr of Kerr Healthcare Analytics, and Ann Kinderman, the Director of Supportive and Palliative Care Service at Zuckerberg San Francisco General Hospital, have been working with Medi-Cal managed care plans and palliative care providers from around the state over the past, 10 months or so, going through a series of topics and tools and resources of interest to help these organizations with implementation of SB1004, which, as you all know, just went live as of January 1st, 2018. So I'm pleased to hand this over to Kathleen and Ann today to talk about some of the issues that have come up in our recent workshops around how plans and providers are addressing common challenges, and some of what they learned through some surveys that they did with plans and providers. We're really happy to have you here today. Our webinar is being recorded and it will be posted on the CHCF website along with the webinar slides. And in the future, we'll also be posting materials from our Topic 5 workshops that were held. With that, I will hand it over to Ann and Kathleen. If folks think of a question during the webinar, you can type it into the Q&A box and we'll have just a few minutes at the end to go over those questions. Thanks so much.
Terrific. Thanks very much, Kate. So this is Ann, and Kathleen and I will be going back and forth on this webinar, talking about different sections. And as Kate mentioned, please do, as questions come up, put those in the chat. And if we can't get to them, we will do our best to address them afterward. So we will dive right in. Next slide, please. So as Kate mentioned, this has been a journey of about a year now that we've been doing this technical assistance series to help both the Medi-Cal plans and the palliative care organizations that are trying to deliver SB1004 services to get ready and then to actually launch their services. So we had topic 1 back last summer that focused in on estimating member or patient need for SB1004 services. In the fall of 2017, we focused in on estimating the costs for delivering SB1004 services. Last winter, we looked at assessing capacity for palliative care delivery in your area and then actually launching the services, more nuts and bolts. We, in the spring, had our topic 4, which looked at how do you know the type of service you're providing, the quality of that service, and how do you sustain and scale and grow your services for your patients or your members. And then we thought it would be helpful, since folks have now had about 6 months of experience at doing SB1004, trying to implement SB1004, try to find out from the plans and from the provider organizations how things are going. Next slide. So our main goals for topic 5 have been to bring plans together with providers to discuss what's been working and what has not been working so far in terms of implementing SB1004. We wanted to look at and talk about what's going on with the status of the services, how many organizations are doing this, and how many patients have been seen, et cetera. We had heard in our prior topics of the technical assistance series some specific challenges that both plans and providers were having in thinking about implementing and then implementing SB1004. We thought it'd be helpful to focus in on those areas that kept coming up as particular challenges. And then we wanted to provide opportunities for plans and providers to come together and dialogue about strategies that they're using, and then gather that information together and share their lessons learned and their pearls of wisdom. Next slide. So where is this information coming from that we're presenting today? The majority of the information, vast majority, is coming from the survey that we did online that I'll talk about in a minute. and also from the 2 workshops that we did that were larger workshops than those that had happened in the first 4 topics, with the intention of bringing together a larger number of people to have even more marinating of ideas and exchange of strategies. And then undergirding all of this is Kathleen and my experience in delivering and starting up programs in palliative care for Medi-Cal patients in particular, and the content of that is what in topics 1 through 4. Next slide. So our survey and workshops had specific focus areas. The information about services and partnerships, because we kept hearing people asking about, how many patients are you seeing, and how many partners do you have? So we wanted to see whether we could gauge that at least 6 months in to be able to share about what we know. And then, as I mentioned, there were these challenge areas that kept coming up when we talked with plans and provider organizations about implementing SB1004. So folks have had questions around how are the different programs staffed? What's the mix of disciplines on the team and the ratios there, and who does what on the team? Because there's a lot of variation, we know, in general in palliative care. There's also questions that came up around what type of services or collaboration are the plans having with their provider organizations? What type of assistance are they providing? There have been a lot of questions around how do we identify the patients or the members who are actually eligible for SB1004 services, because there are a set of clinical criteria, and then there are interview or discussion that actually has to happen with the patient or the member. So how do we find out who is actually eligible? And then there have been a lot of questions around how, once you've identified an eligible patient or member, how do you actually engage with that person such that he or she is open to receiving SB1004 services? And then lastly, we've heard a lot of questions around how do we engage with the folks who are going to refer patients for SB1004 services. So primary care, specialty care, social service providers, et cetera. We had some great participation in both our survey and workshop. So we had 13 plans and 16 provider organizations that responded to our online survey. And for those who went to the workshops, you'll see that the numbers have been adjusted because we had some folks complete the survey after the workshops were done. And we had about 60 people participating in either our Northern or Southern California workshop. Next slide, please. This is what we're going to be talking about today, a general outline, and each of these sections, you'll see Kathleen and I may hand off, but we're going to focus in on each of these topic areas. Next. So the first thing I'm going to talk about is the status of services. Yep. Go ahead, next slide. So the first question that we had is just, what's the experience that the plans and the provider organizations have with delivering palliative care services? And what we found, you'll see in a number of graphs through this presentation, you'll see sets of blue and red bars, and consistent through that, the plans are in blue and the providers are in red. So in this situation, first looking at the plans, you'll see that the majority of plans are relatively new to delivering palliative care, offering palliative care to their members. Almost 70% said that they started these services in 2017 or 2018. And then there are a smaller number that have been doing this a few years, with one plan reporting that they'd been delivering or offering palliative care services to their members for over 10 years. When you look at the palliative care organizations that responded to the survey, there are a significant number that are also new, almost 40% that have been doing this just for a year or less. But then a good number who've been doing this for at least 2 to 5 years, and 3 organizations that have been doing this 6 to 10 years. Next slide. We were interested in knowing how many SB1004 partners both the plans and the provider organizations have, to get a sense of and who everyone's working with. We found that for the plans, there was some plans that reported just one palliative care provider partner, and a plan that reported 10 palliative care provider partners, but the majority reported 3 or fewer. For providers, as you might imagine, the number is smaller, the range is smaller from 1 to 3, with the majority reporting just one plan partner. We were also curious to know, were the plans requiring additional services beyond those that are required by the all plan letter? What we found is that 38% reported that they were not requiring any additional services, so just what is required in the all plan letter. But there are a good number, so the majority are actually requiring additional services beyond the all plan letter. And for those who are requiring additional services, the largest proportion are those that are requiring 24/7 phone support or direct spiritual care services, who not just referrals to the community for spiritual care, but actual direct involvement on the palliative care team. A smaller number are requiring direct medication prescription, formal caregiver assessment, or other home health services like physical therapy or occupational therapy. Next slide. We were curious to know how SB1004 services are being paid for, because there's, we imagine, some variation there as well. So this graph, again, has the plans in blue and the providers in red. And the first 3 categories, going from left to right, are really the base payment model for SB1004 services. And then the 3 categories to the right are additional payments. So when you look at that, and you're looking first at the plans, you can see that almost half of the plans are paying for the services through straight fee-for-service payments. And an equal proportion of those that responded to the survey said that they were using a per member per month case rate to pay for the services. 2 plans told us that they were not providing any additional payments for SB1004 services, because SB1004 services are considered to be part of the capitation that they're paying a provider group to already care for their members. For looking at the plan or the provider organizations, you see that the majority of those that responded to the survey, over 80%, reported that they were being paid through a per member per month case rate, with a very small number that reported a straight fee for service payment. When you look at the categories to the right of the graph, these additional payments, see that a majority of the palliative care organizations reported being paid an assessment fee. So that's when the palliative care provider will go out to see a patient who is potentially eligible, but it's unclear whether they will choose to enroll or whether they'll actually be eligible to enroll. So this is taking into account that, that great amount of work that actually goes into going out and doing an initial visit. Nearly 40% of the palliative care organizations reported they were getting paid incentives, and those included things like avoided hospitalization or ED visits, submitting data. One organization reported that they were getting paid higher rates for palliative care specialists, as opposed to people who were not trained specifically in palliative care or certified in palliative care. And another organization reported incentive payments for completion of PULSE forms with their members and being themselves a member of the Palliative Care Quality Network. Next slide. All right, so some of the juicy information that folks have been likely very interested to know. We wanted to know how many patients have actually been referred for SB1004 services since this January, when the benefit went live. And so looking first at the plans on the left, you see that actually the majority have had fewer than 50 patients, or up to 50 patients so far referred for palliative care services. But with 2 plans, or 15%, that have actually had over 250 patients already referred for palliative care services. So this gives you a sense that we have respondents to the survey that are very different sizes of organizations and levels of development of their palliative care benefits. And we were noted that almost 2/3 of the plans said that they had expanded the SB1004 eligibility criteria, which of course plays into the referral numbers. If you have more people beyond the just required eligibility criteria, then you might imagine, you would have more patients referred. Looking at the provider organizations, you notice that a much larger proportion of the respondents to the survey told us that they had seen fewer than 25 patients referred. But again, we had one organization that reported over 250 patients so far referred since January. Next slide. And then we wanted to know how many members or patients had actually received services. So first, looking at the plans in blue, you see that a large minority of plans said that they had 10 or few members who'd actually received services. But this curve actually has a long tail, with 2 plans that reported having members in the range of 100 or more, compared to the palliative care organizations that responded to us, where over 2/3 of those that responded reported seeing fewer than 20 patients so far. But again, with an organization out to the far right that reported providing SB1004 services to over 100 patients. Next slide. So some reflections on this first part of our data is that for several plans and providers, these services are new, and a small number of patients have received services so far, with a few notable exceptions. The plans are evenly split between fee-for-service and per member per month case rate for the reimbursement approach, and almost 2/3 of plans require additional services beyond those that are outlined in the all-plan letter, and over 60% of the plans that have expanded the eligibility criteria. With that, next slide, we'll start talking about staffing models.
Excellent. Thanks, Anne, and thanks everybody for dialing in today. Next slide. Yeah, so staffing models. Just to reflect on what we talked about even before SB1004 went live, there's information given about what needs to be done, but very little requirements, a lot of flexibility around who can do it. And if you think about the services that are required for SB1004, those are all listed in the column on the left. So providing advanced care planning support, palliative care assessment and consultation, developing and maintaining a plan of care, delivering pain and symptom management, care coordination, and then promoting referrals or providing mental health and social services. All of those items, many members of the interdisciplinary team can have at least some role in delivering those services. So advanced care planning could be undertaken primarily by a physician or a nurse practitioner or an RN or a social worker or a chaplain. You could even include other disciplines there. You could have a community health worker that gets that going, or some other trained layperson. And so if you think of in terms of identifying an issue, perhaps doing an assessment of looking for distress, all the way up to doing a formal assessment and then offering management and follow-up, there's many different roles that each of these disciplines can play. So there's a very pertinent question about, well, how are these services being staffed? You could cover all of these required services with very different configurations of disciplines. Next slide, please. So we asked, and people actually told us. So we asked them about which of 10 possible disciplines were actively involved in delivering care to patients on the palliative care team for those that were delivering SB1004 palliative care. None of the 16 provider teams that responded to the survey said they were using a psychologist, but otherwise there was at least some representation of each of these 9 disciplines, and at different prevalence levels. So first of all, and not surprising given the population that's being served, everybody is using social workers. There's a social worker that's an active part of the team on each one of the 16 organizations that responded to the survey. 94% of the organizations are using RNs, 88% chaplains, which we were really, really delighted to see, and that corresponds to the number of programs that are delivering direct spiritual care, and why so many plans are able to ask for and then have direct spiritual care included as one of the required services for their palliative care vendors. 63% are using physicians, 56% nurse practitioners, 31% licensed practical nurses or licensed vocational nurses, 31% are using community health workers, and then a smaller percentage, 13%, using both physician assistants and pharmacists. And then these groupings of these different disciplines, there was variation there as well, and also in terms of the number of disciplines involved on each team. Next slide, please. So if you look again at the distribution, what we saw with these 16 provider organizations is that they ranged from having 2 to 8 disciplines on their palliative care teams. Of the 10 that we asked about, there was only 1 team that delivered care using 2 disciplines. 2 teams used 3 disciplines. 5 teams used 4 disciplines. 4 teams used 5 disciplines. 1 team used 6 disciplines, and there were 3 teams that used 8 disciplines. And you can imagine that the way that work is distributed is quite different depending upon the number of disciplines on the team. That 4 and 5 disciplines, that accounted for over half of the respondents, and that's not surprising. It's a if you think of the core palliative care team members of physician, nurse, social work, and chaplain, I'm not surprised that the largest proportion of respondents had those 4 disciplines there. Next slide, please. So just some reflections on what we learned about the staffing models, and this is both from the survey and from comments that were shared during the workshops, is that teams are appropriately interdisciplinary. Folks are delivering palliative care in the preferred way, which is where it's not a single discipline service model. It takes a team to deliver this care correctly. Almost everybody's using RNs and social workers, but beyond that, there was significant variation in team composition. And whenever I see variation, I wonder why. What is driving the variation? Is it just the custom of your organization? Have you always delivered? Have you been doing palliative care for a while, and have you always used these 2 or 3 or 4 or 5 disciplines? Is that just the way you do it? Was it, expedience? Was it that you wanted to be a palliative care providing vendor, and you happened to have these folks on hand, and you could have done it a different way, but this was what was handy, so that's how you did it? Is team composition driven by feasibility? So in your area, was it relatively easier to recruit or to retain particular disciplines? Did you, for example, start with a nurse practitioner model, but then when that person left, you realized you couldn't replace that discipline, so you went with a nurse social worker model, or perhaps you were looking for a nurse practitioner, you couldn't find one, so you wound up engaging a physician? Does your model reflect your view of what it takes to deliver the highest quality care possible? So do you feel like, we really have to have a pharmacist on the team to do this right? Or we really have to have a chaplain on the team to do this right? Or is it a question of efficiency? Is it that, we can deliver this care, at a good ratio of quality to cost if we use a social worker RN model with physician directorship versus using a nurse practitioner? Do you feel like that's the best, most efficient way to deliver care? And, every organization will have different answers to what their motivation was, but we just want to encourage people to think about it. What is driving your staffing model choice? And also to think about, how will your current model hold up over time as volumes increase, which we do believe they will over time, and then also if it becomes necessary to become more efficient. If a trend arises where perhaps you couldn't secure as much reimbursement as you had in the past for delivering palliative care, if you needed to become more efficient in order to match up your effort with the available payment, how might your model change? Next slide, please. So next topic is plan-provider collaboration. So how are the plans and providers working together? We've heard, in the course of workshops 1 through 4, that there were different ways the providers and plans were working together, and even if they were working together, to what extent and what topic areas. So we made an effort to ask about that in the survey and then also to talk about it in the workshops. Next slide, please. So what we saw is that there's quite a bit of variation across different areas that plans and providers might collaborate in. And for the survey, and as a starting point for the workshops, we identified 8 possible areas where plans and providers could collaborate: identifying eligible members, educating members about the palliative care benefit and the program, referring provider education. Plan participates in interdisciplinary case reviews along with the provider organization, care coordination and case management support, specific efforts around helping the providers secure authorizations for services and meds and supplies, which can be really important in this often very sick population with some very acute needs, referrals to social services, and referrals to mental health services. And what's reported in the two columns to the right is the proportion of plans that reported having frequent and direct involvement in each of those areas. And then on the far right, the proportion of plans that reported having no involvement at all in those areas. And you see that there's quite a bit of variation, just in terms of the first one, identifying eligible members. Well, the third of the plans say that they are frequently and directly involved in this effort. There's one plan that wasn't involved at all, and everybody was in the middle. There seemed to be a general lack of a lower level of engagement around educating members about the palliative care benefit, but no plans every single plan was involved at least a little in referring provider education, and a couple of them involved frequently and directly. So we see that across topic areas, different plans had different levels of engagement in these areas. Next slide, please. And this is also true plan to plan. So if you look at all 8 of those potential involvement areas together, and you look at the 12 plans that offered information about the degree to which they were engaged in these topics, you see just about as wide a variation as is possible. And the color groupings reflect sort of general categories of intensity of involvement. So plans 1 through 3, they were frequently and directly involved in 5 or 6 of those 8 possible topic areas. 2 of those plans were involved in every single topic area, at least to some extent. One plan, there was one topic area where they weren't involved at all. Those next sets of plans 4 through 7, in that kind of pinkish color, there were a fewer number of topic areas where they were frequently and directly involved, but they were involved at least a little in every single one of those. Plan 8, they had 1 area where they were frequently involved, but 3 areas where they weren't involved at all. Plans 9 and 10, I call them the moderates. They weren't frequently and directly involved in any topic area, but they were involved in every single one at least a little bit. And plan in 11, 12, they're kind of laid back, maybe the Southern California surfer plans, where they're not frequently directly involved in anything. And there were at least 2, and in another case, 3 areas where they weren't involved at all. So much less direct engagement than what you see in those plans 1, 2, and 3. Next slide, please. And so you see that variation, and there's no right answer, at least now, only 6 months in, as to, well, what's the right level of engagement in which area? And it's worth thinking about if you are a plan or you are a provider that's engaged with the plan, well, what might the purpose of collaboration be? Is it intended to promote quality and assurance to make sure that things are being done well? Is there a quality improvement aspect to it where the plans and the providers are working together to figure out better ways to do things? Is the intent to promote better coordination of services between stuff the plan covers and stuff that the palliative care team covers, just to make sure everybody knows about all the options and everybody's on the same page? Is the collaboration intended to lower the burden on the provider? So if the plan is taking on a larger role in identifying patients or in doing educational work or in doing case management, is the intent there to lower the burden on the provider, which would make it possible to deliver palliative care services at a relatively lower cost? Is the idea to monitor plan expenditures to make sure that folks aren't enrolled in the program for a longer period of time than which they would benefit? Or is it an educational intent, both the plan helping to educate the provider or the provider helping to educate the plan if there's some differential in experience with palliative care? So when I see variation, that means that there's an opportunity to reassess practices, and we'd encourage people to think about, what is your level of collaboration, plan to provider, and how is that working out? Are there any areas where you might add or remove collaboration? Might you increase or decrease intensity? And what are the ramifications for adding or removing a collaboration area? What does it mean to engage in this way? And I'd encourage you to be intentional about it, because there's ramifications in terms of time investment on both the plan and the provider to make collaboration happen, but there can also be some really good things that come from it, so it's worth considering. Next slide, please. So another area that we focused on that people had really identified as an area where they were still casting about to find the best possible method is identifying eligible patients and members. And for these next three areas, identifying eligible patients, engaging with patients and members, and then engaging with referring providers, it can be a little hard to think of them in segments as three separate steps because they all seem to kind of come to, they all kind of go together. But we're going to try to examine them separately to see if that helps us to tease out promising versus disappointing practices. Next slide, please. So reflecting back on what we talked about in topic one, what are the eligibility criteria for SB1004? There's sort of three big categories. You have to have one of the four qualifying diagnoses, at least for the base, the minimum criteria spelled out in the all plan letter. There has to be evidence of advanced disease, and that's reflected in either specific biomarkers like an ejection fraction or a MELD score, or I wouldn't be surprised if this patient died in a year, those sorts of assessments. And there's also some criteria that speak to patient and family preferences, specifically a willingness to have a trial of home-based care as opposed to, say, going to the emergency room, and also a willingness to engage in advanced care planning. And those are three very different types of criteria. If you think about where you find that information, well, you can find some of it in claims and authorization data. You can find some of it in electronic health records. You can get some of it if you do a, sort of an in-person or an over-the-phone screening or assessment. But it's really hard to get all of those eligibility criteria in any single database. And that means that you typically have to have a range of strategies or even a range of steps to verify eligibility, and that can make it kind of complicated and hard to do. Next slide, please. So in our survey, we asked folks about some strategies that we had heard about and whether or not they were folded into the portfolio of approaches that were used by particular plans and particular providers. And you can see that, just about everybody is asking primary and specialty providers to refer patients directly to palliative care. 100% of plans endorse that. 81% of providers said, yeah, that's part of how the patients who refer to us get identified. Similarly, there was a substantial portion of plans and a majority of providers who said they asked non-physician staff at clinics and hospitals and physician offices to refer directly to palliative care. A surprising number said that they invite members to self-refer. So 62% of plans and 44% of providers. A particular favorite was a plan IDs patients through claims data and sends those lists to providers. 54% of the plans say they're doing that. 63% of providers say that's happening, and so on with a little slightly lower frequency for the remaining items. And then in addition to saying, well, what are you doing? And we asked this in both the survey and in the workshops. We wanted to know, well, what's not working and what's working. Next slide, please. So we're going to start with what people identified as being the least effective strategies, because these were sort of the most heartfelt responses that we got both in person and through the survey comments. This does not work. People were pretty clear about that. Relying on palliative care, on primary care providers and specialists to just make the referrals. People were frustrated by that, and a particular area where there was frustration was this concept of doing provider education meetings, which were called lunch and learns, which apparently there was much more lunching than learning than what was going on, because folks would do these and they feel like it didn't have any impact on the ability of providers to identify patients. Providing lists to palliative care providers, so the plan runs a list based on claims data, sends it to the provider organization, and invites them to do cold calls. That was endorsed as being not effective by some respondents and some workshop attendees. Some felt that identifying high-risk acutely ill members in concurrent review wasn't effective because these folks had so much going on and were likely to go to SNF or rehab that by the time they became appropriate to enroll in the palliative care program, it was just past the time that it was possible to get them enrolled, and that relying on community partner organizations was also not effective. But those were the perceptions of the plans. For the providers, it was an even a larger proportion said that, cold calling members from lists provided by health plans just doesn't work. And here's a representative quote: information is often incorrect. Members are suspicious. There's a lack of medical information and barriers to obtaining this from the palliative care provider. And there was also frustration expressed with waiting for referrals to come from physicians' clinics or for patients to self-refer. But one person noted, and I thought in a very interesting way, that just waiting for referrals to come in, that was not an effective strategy. You had to do something. So what did folks identify as a potentially the most effective strategies? Next slide, please. Well, what's interesting here is that a number of the strategies that were identified as being least effective, other folks identified them as being most effective. So first, the ones that were sort of given the most homogeneous, endorsement, there was a lot of support for having plan case managers and nurses identify patients to refer to the palliative care program. And that came from both plans and providers. And the reason why is this pre-existing relationship made it a very not only an effective way to find the patients, there was access to the pertinent information, but then to facilitate the referral to palliative care based on an existing relationship. There was also endorsement of palliative care teams participating in clinic and hospital rounds. Some folks said that data mining actually worked pretty well, and in particular, if they used the claims data as a starting point, and then they used case managers or social workers to filter further, and then that list was passed on to the provider organizations. Some noted that cold calls do work, and that's in particular when the case managers or social workers called the patient on behalf of the physician to describe the program. Here, the idea was that it mattered, who did it and how they did it and when they did it versus somebody who maybe wasn't completely familiar with palliative care or completely familiar with the patient doing the cold call. A twist on the claims data is that the plan sends the list of patients to primary care specialists and invite them to contact the patients or make the referral based on that, as opposed to sending a list to the provider organizations. And my favorite response of a most effective strategy was somebody said none. No strategy is effective. And I'm hoping that person will find an effective strategy eventually. Next slide, please. So just one of the things that we wanted to emphasize, and what we really heard in the surveys and in the workshops, is that there are a whole bunch of identification assets, and we encourage people to use all of them. There's claims data, there's plan staff and programs, there's the SB1004 palliative care providers, primary and specialty providers, non-physician staff in the offices who can recognize patients who might be eligible. There's the hospital palliative care teams, where it's a very natural progression from being cared for by them to being cared for by a community-based program. Home health agencies who are in the home who could recognize that, hey, this is a patient who needs some more support. Community agencies that are likely to have contact with these patients over time and might recognize a need, and then the members and patients themselves. All of those assets can be used in different ways and in different combinations to identify potentially eligible members, and many people are using different combinations of them. Next slide, please. So just some reflections. Again, there's lots of variation, so there's probably a lot of strategies that each individual plan or provider organization hasn't yet tried that they should be open to. As we said, some strategies that have been flagged as most effective have also been flagged as least effective. So if something's not working, think about how you're doing it, not just if it works, sort of generally. There was a lot of issues with the palliative care teams doing cold calls based on claims data, but again, think about the who and the why. And most folks endorsed a strategy of adding different ways of identifying patients versus eliminating any particular strategy, even if it wasn't yet being effective. Next slide.
Great. So I will be taking over to talk about strategies to engage patients or members. And this is the component where you've already identified a patient or a member as very likely eligible or definitely eligible for SB1004 services, but then how do you actually get them to engage? Next slide. So there are questions around how you actually go about informing members or patients about services being available, and then how to increase the likelihood that once they are identified and engaged with, that they will accept the services. I wanted to just put a reminder here that we did talk about this a bit in topic 3. I may have the link again to the SB1004 website on the CHCF page, and you can look back at topic 3 where we talked about informing patients about palliative care, specifically looking at the challenges with the Medi-Cal population and providing some suggestions for addressing those challenges. So you may want to go back and take a look at that if you weren't able to participate in topic 3. Next slide. So we wanted to know what strategies the different organizations are using to inform members or patients about the availability of palliative care services. So the plans, again, in the blue bars, the majority said that they were using newsletters, whether that's printed or emailed to their members to let them know about services. A large proportion are also saying that they're having the palliative care organization do specific outreach to members who have been flagged as potentially eligible, and doing engagement themselves, having staff from the plan actually reach out to their members who they have identified as likely eligible. Less commonly, but still quite popular, the plans reported outreach to referring providers about SB1004 availability and using printed brochures. For the palliative care organizations, the most popular strategy was using brochures, which made a lot of sense to us, thinking about when and where you would come to meet a member if you were a palliative care organization that didn't have a relationship with them beforehand. And not surprisingly, the majority of palliative care organizations said that they were doing outreach to the members who were potentially eligible, also doing a fair amount of referring provider outreach, and that the plans that they were working with were also doing engagement with their members. Next slide. When we talked about, both in the survey and at the workshop, we wanted to know what are the biggest challenges that the plans and the providers are facing in engaging patients and members. From the plan perspective, they said, you know, we're doing a lot of these newsletters, but we really don't know, or we're suspicious that a lot of our members are not actually reading them. Or, you know, even when we try to do our outreach, it's hard to contact them because of, you know, they've lost their phone or they don't have a phone at all. And the plans also flagged a lack of time for outreach and education to their members because they've been so busy actually just developing the infrastructure and all of the components that they need to get the SB1004 benefit up and running. From a palliative care organization standpoint, they identified difficulty getting information from the plans or integrating that with the plan, integrating themselves with the plan case management. So they need to get the clinical information, of course, about the members to know that they're eligible, and having a good communication flow with the plan case management staff. But by far, the most significant reason that was identified by providers was the patient instability. This idea of, you know, they might not have a home, or they might have to move around and be marginally housed. They might not have consistent access to a phone or be outright homeless. And the providers also said this just takes a lot of time, and that's challenging for our staff. Next slide. We wanted to talk about or find out what the experience has been in terms of why members or patients decline services. So first, looking at the plans, so we asked people to score these different categories, these different reasons. What's the most common reason that the members decline services, and what's the least common reason? And so for the plans, the most common reason that they had experienced that their members declined services is that they were unfamiliar with the palliative care organization, or therefore didn't feel comfortable signing on for services. The next most common reasons from the plan perspective was that they felt that the member didn't see the benefit of palliative care services, or that there was concern that enrolling in SB1004 palliative care might limit other services that the patients or the members are getting. There's a little bit of a lot of overlap, but some difference in terms of what are the top reasons from the palliative care organization's perspective. For the palliative care organizations, the most common reasons that they had been, when they are engaging with patients about these services, the most common reasons for declining were that, again, that the patient didn't see the benefit of the services, not liking home services, wanting to have privacy and feeling uncomfortable having strangers into the house was a reason that was much more commonly listed by the palliative care organizations than the plans, and the lack of familiarity with the palliative care organization was also a prevalent reason. But I thought it was significant that neither the plans nor the providers thought that the problem of not being willing to engage in advanced care planning was an issue. Next slide, please. So we wanted to know, again, what works best. And by far and away, in both the surveys and in the workshops, what came up again and again was that you really need face-to-face, ideally, or at least direct phone contact with the patient or the member to really explain what this is about, to find out what their situation is, and to understand why they might benefit from this. The time that was flagged as a challenge was also considered a strength, or a very important component in terms of helping patients to engage with palliative care services. This helps to build rapport and trust, and actually just talk about what is palliative care and why might you actually benefit from this? Why might it be good for you? One thing that came up, particularly in the workshops, that a bunch of palliative care organizations are doing is having an initial call with patients who might be eligible, and then saying to them, you know what, you don't have to make any decisions today. You can think about this, and I'll follow up with you in a week, so that there isn't, it doesn't feel like it's a sales call. So that the patient or the member really has space, and they know that they can just think about it. A number of palliative care organizations said that they thought it was a great idea to actually meet the patient, whether they're in an acute hospitalization or when they're in a skilled nursing facility, to have a face-to-face interaction again. Another thing that came up in the workshop that we thought was a great strategy was that one palliative care organization said that they were using both the logos of the health plan and the palliative care organization on their palliative care materials for the SB1004 patients, so that really communicated, again, this transfer of trust of, we're not this organization coming out of nowhere. We're an organization that's actually directly working with your plan that you know and hopefully trust. Highlighted frequently was getting support from the referring provider, ideally with a warm handoff and provider to provider or physician to physician, talking about the needs of the patient. A few organizations said it's really helpful if the plan either calls or sends a letter to the patient to prime them about the palliative care organization reaching out, so that it wasn't just a call out of nowhere, as Kathleen was talking about these cold calls. And there are people who really highlighted that it really makes a difference how the provider who's doing the referral explains the service, which makes a lot of sense. Some organizations said, we have the same case manager contact at the plan who really knows what these services are and can communicate that very directly to and consistently to their members who are eligible. It's also convenient for the palliative care organization to have a single point of contact. And then what came up again and again is this idea around, there may be other needs that are not as prominent for the patient as enrolling in palliative care services. It might be their electricity is going to get shut off, or they don't have access to food. And if you, as a palliative care organization, are able to work either independently or with the plan to really address those needs, it's going to lead back to palliative care and, again, build trust. Next slide. So reflections on what we've learned from the folks who have participated in the workshops and the survey is that there are more patients who are finding out about services than might have been expected. About 30% of the provider organizations actually said that patients had contacted them about SB1004 and enrolling. Psychosocial factors have a really big impact on providers' ability to engage with patients. It's really important to emphasize strategies that transfer trust. So these introductory letters, calls, warm handoffs, that's key. And this idea of face-to-face contact, getting in front of the patient, as one person put it, is really key. And some reasons that patients and members decline services may be amenable to education. So again, the investment of time may be well worth it. Next slide. So our last section of strategies is talking about engaging referring providers. And we'll say that, we saw a fair amount of frustration on the side of the plans and the provider organizations that participated in the survey and the workshops around how do we get to folks who may be unfamiliar with palliative care or unfamiliar with this benefit to help them identify patients who may be eligible. Next slide. So the topics that we looked at were how are organizations reaching out to referring providers, what are the barriers, and what are the most effective strategies so far. So recurring theme here. And I'll just mention that we did go over this in topic 3 as well, and the references there. Next slide. We looked again at how the strategies that are being used by the plans and the provider organizations to reach out to referring providers. Very common for the plans to use newsletters, also to do individual outreach to providers who are caring for patients who are eligible, using brochures and handouts, and to a lesser extent in person. For the palliative care organizations, their most common was doing the individual outreach, not surprising, getting referrals and then going out to the patients, or doing in-person sessions with the referring providers, and to a lesser extent brochures and handouts. The particular providers that were targeted in terms of outreach were most commonly for both the plans and the provider organizations, primary care providers, specialists, and case managers, more so than social workers or even inpatient palliative care organizations. Next slide. When we asked about the biggest barriers to referring providers being engaged and actually referring patients, from the plan perspective, they thought that the biggest barrier was that providers are hard to reach. You just couldn't get them on the phone, or you couldn't get them by email. Also very common from the plan perspective that they misunderstand what palliative care is. To a large degree, this misunderstanding or confusion that you would limit treatment if you refer to palliative care. From the provider perspective, the most common reason was this misunderstanding of palliative care, of not getting the principles or the benefit for their patients, and also this problem of they're hard to reach. Next slide. When we pulled together the information both from the surveys and from the in-person workshops, again and again and again, the biggest thing that came up was this lack of time, or I'd say attention, on behalf of referring providers. They didn't have enough time to hear about the services, and they also just didn't have time to have the conversations that were needed with the patients to think about their goals of care and think about who might benefit. There was highlighted this lack of understanding, first of just the benefit, the SB1004, who qualifies, but also just what palliative care is. Not having access or contact with the providers. And I think one thing that was highlighted is that referring providers want to be able to send all of their patients who need palliative care, not just the Medi-Cal patients. And it was an interesting thing that we saw two different sides of the same coin. One was that some providers had the expectation that the palliative care team would really take over. They were overwhelmed with the patient, and they wanted the palliative care team to really take over. And some providers were afraid that that might happen, that they would lose control or they would push patients into hospice and things. So you might see both sides of that. And some providers actually just don't know their patient very well. They don't come to clinic that much, and so they were pretty unfamiliar with them. Next slide. In terms of the most effective strategies, the face-to-face meetings, again, came up as the most important strategy, making that in-person contact with the providers so that they know who they're dealing with. And a number of folks in the, particularly in the workshops, but also in the surveys, talked about physician-to-physician conversations about specific patients. So having a physician from the palliative care organization reach out to the physician who might be referring. Focusing in on some key messages that it's not just extra support for the patient, but it's extra support for the physician. One organization said, the terms that they use are saying, we're the eyes and ears at home, or we're available when your office is closed. We can really extend your reach. Some suggested engaging staff and non-physician providers to get the physician time, working with the hospital discharge planners, and then having a personal connection to the folks who are actually receptive to palliative care. Next slide. So reflections on engaging providers is that time is a really big factor for everyone, for the referring providers, for the plans, and the palliative care providers. It's hard to get time with the referring providers, but face-to-face is frequently identified as effective strategy. Participants were highlighting not just education, but awareness. So getting in front of the provider and making sure that it's at top of mind consistently. And then these practical aspects like making referrals easier was key. Most organizations so far have focused on physicians' case managers for outreach, but you should really think about meeting providers' needs. If you want to engage them, think about what your value added is for them and this idea of extra support for the physician. So with that, I'll hand back to Kathleen to go over some key points really quickly.
Sure, yeah. Next slide. Just running through the topics that we spoke about today, staffing models. What we see is that there's significant variation in team composition. There's not just one right way to staff a palliative care program. We encourage everybody to reflect on why you're using your current model, and then also to think about how do you anticipate that your model will work as volumes increase, and then also how it will work over time if it turns out that you need to operate more efficiently. Next slide. Plan provider collaboration. Again, there was a lot of variation in the areas in which plans were engaged and in the intensity of involvement. And we encourage everybody to seek partner perspective on the current collaboration practices. Plans should ask providers, how's it working for you? Providers should ask plans, how are you working? How's it working for you? And then reflect on what might be gained or lost if your practices are modified. Next slide. In terms of identifying eligible patients and members, it seemed to work best if the plans and the providers share responsibility for this and share their assets. The plans have access to some information the providers don't have, and the providers have opportunities to engage with folks in the ways that the plans don't have. The strategies that were seen as most effective by some folks who we work with were seen as least effective by others, and that's just a cue that it depends on how you do it, not just what you do. And then consider new twists on old models. So for example, instead of generating a list of potentially eligible members and sending that to the palliative care provider, think about sending it to the primary care providers or the specialists and inviting them to use that to identify potentially eligible patients. Next slide. Engaging with patients and members. So emphasize strategies that transfer trust. So introductory letters, warm handoffs, leveraging existing relationships. As Anne said, getting in front of the patient is key, so that opportunity to see someone face to face or talk to them on the phone to really take the relationship into something that's direct. And then also remember that some of the reasons that patients or members decline services, those may be amenable to education. If you explain you don't have to give up treatment options to enroll, that might help to alleviate some fears. Next slide, please. And finally, engaging with referring providers. Remember that time is a huge factor for everyone, and being mindful of that will help you be successful. Education, awareness, and practical aspects, so making referrals easier, are all important. And then really emphasize meeting providers' needs. Emphasize that you're an extra layer of support. Emphasize your value added. And with that, at 12:59, we come to the close of this. So we wanted to close by thanking our colleagues from the plans and the provider organizations who completed the surveys and participated in the workshops. There's a couple contact sources for you there if you have questions about SB1004 or about the technical assistance series. And a reminder that the webinar recording and the slides and the materials from the workshops will be available on the CHCF website. And then with about, I think, 30 seconds to spare, I'll hand it back over to Kate Myers to close this out.
Thank you so much, Kathleen and Anne, for packing a whole lot of information from the workshops and surveys into just 1 hour. We didn't have any questions come in on the Q&A, so I think what we'll ask is that if folks have follow-up questions as you review these materials in more depth, or you refer colleagues to the recording of this webinar once it's posted, just get in touch with us. You have my email address on that last slide, and we'd be eager to hear from any of you with questions or ideas or suggestions for other ways in which the California Healthcare Foundation and our partners like Anne and Kathleen can continue to support you in your efforts and implementation. But again, thank you for coming, and thank you, Anne and Kathleen, for leading us through this important material. Have a good day.